Hello, everyone. You're all very welcome to this evening's event. Thank you all for joining us for this webinar, which we are holding to mark Eating Disorders Awareness Week 2026. So the theme of this year's Eating Disorders Awareness Week is connection and community. And we're really delighted to be joined by members of the multidisciplinary team here at St. Patrick's Mental Health Services Eating Disorder Service to explore this theme in more detail. So, over the next 90 minutes, our speakers will be looking at various factors influencing eating disorders. So, that includes the use of weight loss medications, binge eating disorder, physical health complications of eating disorders, access to healthcare and stigma, and recovery and treatment from eating disorders. So, tonight's presenters are Dr. Gary Cooney, who's a consultant psychiatrist here in the Eating Disorder Service at St. Patrick's, Michelle Ward, a candidate advanced nurse practitioner in eating disorders, Dr. Joan Costelloe, a clinical research fellow, and Laura Griffin, occupational therapist. So following all four speakers' presentations, we hope to have time for a short Q&A. So you can submit your questions throughout the webinar using the Q&A function at the bottom of your screens. If your questions for a specific speaker, please do be sure to include their name so we can direct them. We can direct your question to them. And finally, for anybody with accessibility requirements, you can turn on closed captions by clicking on the live transcript function in your Zoom window. So that's it from me for housekeeping. We'll get started and I'll hand you over to tonight's first speaker, Dr. Joan Costelloe, who'll be looking at the physical health complications of eating disorders. Welcome, Joan. Thank you for your time this evening.
Hi, thanks very much. Good evening, everyone. My name is Joan Costelloe, and I'm one of the doctors on the eating disorders team in St. Patrick's Hospital. So I would like to present on the physical health complications of eating disorders. So I'm conscious that lots of different types of people might have joined this webinar tonight, including people who may have struggled with eating disorders themselves, or who may have family members or friends who have. And there may possibly also be some clinicians joining as well. With that in mind, I aim to explain any of the medical terms that I am using, but if anything isn't clear, I'm happy to take any questions at the end also. So this is the outline of the presentation. I've grouped the physical health problems into different organ systems. So I'll start off by covering the evaluation, nutritional rehabilitation, and electrolyte abnormalities that can be seen in eating disorders, and then move on to the gastrointestinal system, cardiovascular system, endocrine system, gynecology and reproductive system, musculoskeletal system, and neurological system. I'll also include hematology, oral, dental, eye, ear, and skin complications, and then finally talk a little bit about weight stigma and weight inclusive care and the links between physical health and eating disorders. So just as a brief introduction, in terms of describing eating disorders, an eating disorder is defined as a persistent disturbance of eating behavior that impairs health or social function. There can be an intense preoccupation with food, weight, shape, and size. And there is a self-perpetuating mechanism, and a social-cultural desire for thinness is thought to underlie many eating disorders. Anorexia nervosa is characterized by low body weight, and the weight loss is self-induced by restricting food and can be seen in combination with purging in terms of vomiting, excessive exercise, or inappropriate use of other medications like laxatives, diuretics, or appetite suppressants. This distortion of body image and preoccupation with weight and shape and intense fear of weight gain. There can also be endocrine dysfunction, for example, amenorrhea, which is loss of menstrual periods, which I'll talk more about later. Bulimia nervosa is characterized by binge eating and compensatory behaviors like self-induced vomiting or misuse of laxatives. Again, there's a preoccupation with body weight and shape and marked distress or significant functional impairment. Binge eating disorder is characterized by recurrent episodes of binge eating accompanied by distress, guilt, or disgust, and significant functional impairment, but there are no compensatory features seen in binge eating disorder. It's important to recognize the significance of eating disorders. There's a lifetime prevalence rate of approximately 8% of women and 2% of men. Men and boys are significantly under-identified. Eating disorders also have a high morbidity and mortality rate. The mortality rate of a patient diagnosed with an eating disorder is 2 to 5 times higher than age-matched controls who don't have an eating disorder. And I haven't mentioned other eating disorders here, which we also see, including ARFID and atypical eating disorders. So initially, I'm going to start with the assessment and evaluation, nutritional rehabilitation, and electrolyte abnormalities that can be seen in eating disorders. So initially, there's an assessment based on weight, the rapidity of the weight loss, the length and severity of calorie restriction, the vital signs that includes blood pressure and heart rate, the blood results, and ECG findings. And an ECG is a trace of the heart. We then assess for the appropriate level of care to determine if that's inpatient or outpatient care and in a general hospital or in a psychiatric hospital. One of the mainstays of treatment is nutritional rehabilitation, which is the refeeding. There is a syndrome called refeeding syndrome, which is a certain set of clinical and metabolic derangements that can occur when you start introducing a meal plan or nutrition. And it's caused by sudden increase in insulin levels, which move certain electrolytes into the cells and out of the bloodstream. So this can present with complications like edema, which is swelling in the tissues, heart failure, arrhythmias, that's abnormal heartbeats, respiratory failure, muscle weakness, seizures, and can cause death. So the most common abnormalities that are seen here are low phosphate, low glucose, low potassium, and low magnesium. So the treatment is replacement of these electrolytes, regular blood test monitoring, the meal plan itself, and vitamin supplements. So electrolyte abnormalities are also commonly seen in purging. So purging can be vomiting, laxative abuse, or diuretic abuse. And electrolyte problems are also seen when people stop purging. Laxative abuse is associated with the most severe levels of dehydration in terms of eating disorder behaviors. The most commonly affected electrolytes tend to be potassium, sodium, and bicarbonate, but the fluid balance and the acid-base balance can also be affected. Hypokalemia can be unpredictable. This is low potassium, and it can cause cardiac arrest via arrhythmias or regular heartbeat. There needs to be careful monitoring when replacing sodium. When people stop purging, that can lead to a severe rebound edema. So that's a sudden increase in fluid buildup in tissues in certain body areas. There are guidelines for managing these complications, such as the MEAD guidelines, which is the Medical Emergencies in Eating Disorder guidelines. It's also important to emphasize that when people are purely restricting, the blood tests and the electrolyte levels may be normal as the body goes to great lengths to protect the homeostasis or the balance of these electrolytes. And that can lead to a misconception that some people have that they think they are not sick enough to seek treatment because their blood tests are not abnormal. And this frequently isn't the case. In terms of the gastrointestinal system, I've grouped this into complications due to restriction and complications due to purging behaviors. So gastroparesis is reduced peristalsis in the stomach, which is reduced squeezing of the muscle in the stomach. That causes problems with gastric emptying and can cause bloating, nausea, and early feelings of fullness. And it's seen very commonly in prolonged nutritional inadequacy. Constipation is also seen due to reduced gut motility from caloric restriction and dehydration. There's also a syndrome called superior mesenteric artery syndrome, which is due to loss of the normal fat that surrounds certain blood vessels. When this has atrophied, the blood vessels can then press in the duodenum, causing obstruction, and this can present with abdominal pain and vomiting. We also commonly see liver abnormalities. The most common here would be starvation hepatitis, which is autodigestion of the liver tissue for fuel. That classically shows high levels of AST and ALT, two blood tests. And this starvation hepatitis usually resolves completely with nutritional rehabilitation. In terms of purging behaviors, it's very common to see GORD, which is gastroesophageal reflux disease, and esophageal erosion and gastritis. Here, repeated vomiting causes mucosal damage and can lead to GI bleeding and precancerous changes like Barrett's esophagus. The reflux occurs because the ring of muscle in the lower esophageal sphincter becomes more stretched out and more lax, and then reflux of stomach contents becomes more common. It's also possible to experience tears in the esophagus, which can be partial thickness or full thickness. And it is recommended that anyone who has GI bleeding or has had 5 years or greater of purging seek an OGD, which is a camera test to assess the stomach. Parotid gland hypertrophy can also occur in purging. So this is swelling of the two glands located on either cheek. This may not resolve completely with eating disorder treatment and recovery. And when somebody stops purging, it can occur that there is more acute swelling and pain due to what's called acute sialadenosis. This usually resolves within a few weeks and can be treated with conservative measures. In terms of binge eating disorder, it's also common to see reflux and gastric dilatation and edema or fluid shifts and fluid buildup in the tissues following binges due to insulin surges. In terms of laxative abuse, this is thought to increase the risk of atonic colon or a flappy colon, and also melanosis coli, which is a buildup of pigment in the colon, and it's unsure what significance this has. In terms of the cardiovascular system, this is a common area where complications are seen. About 50% of anorexia patients have changes on their ECG or their heart tracing. It's important to highlight that hypoglycemia or low blood sugar can lead to sudden cardiac death. And many arrhythmias or many instances of abnormal heart rhythm may not present with symptoms that the patient can feel themselves, and they may only be picked up on an ECG or a trace of the heart. These type of arrhythmias can include bradycardia, which is a low heart rate due to increased vagal tone, and then an increase in heart rate with minimal exercise. There is also QTC prolongation, which again is another type of abnormal heart rhythm, and that can be caused by low potassium and low magnesium. Cardiomyopathy is reduced cardiac muscle mass, which comes from protein breakdown, and this leads to reduced heart pump function. There's also orthostatic hypotension, which is a drop in blood pressure, usually on moving from sitting or lying to standing up. This is due to dehydration and poor cardiac output and can present with dizziness and fainting. Pericardial effusions can be caused by refeeding too rapidly, where fluid can build up around the heart. And peripheral edema is the abnormal accumulation of fluid in certain tissues, for example, in the legs and in the lower back. This can be seen in refeeding, when people stop purging, and with the lack of certain vitamins, and also in heart failure. In terms of the endocrine system, the most common abnormality is what's called hypothalamic hypogonadism. So this is due to malnutrition, and the body suppresses certain functions to conserve energy. And this leads to the body returning to pre-adolescent levels of hormones, for example, lower levels of estrogen and testosterone. In women, this estrogen deficiency can lead to amenorrhea, which is the absence of menstrual periods, and irregular menstrual periods. The low testosterone in males can cause reduced libido and reduced sexual function and reduced muscle mass. The other endocrine complication is impaired growth or failure to reach the height that could have been reached initially. This stunted growth can occur if the onset of the eating disorder is pre-pubertal, and that's due to growth hormone resistance. There is also a feature called SICU thyroid syndrome, which is where abnormal thyroid function blood results are seen in malnutrition, and this can be confused with hypothyroidism. But this syndrome itself resolves with nutrition. Hypoglycemia or low blood sugar is very serious, and it can lead to permanent neurological damage, seizures, and even death. This is seen in eating disorders due to low glycogen stores. It can occur before meals or following meals, and people or patients may not experience any warning symptoms of low blood sugar. Temperature regulation difficulties also occur, such as increased sensitivity to cold, lack of shivering, fine downy hair growth called lanugo hair, and their extremities feeling cool and red-blue color changes. It's also possible that thyroid hormone can be abused or misused. For example, overuse or use of non-prescribed levothyroxine for weight loss. So this increases metabolism, which can affect bone density, also the heart rate, and can cause palpitations. In terms of the gynecological system, the classic teaching is that 90% of women who achieve 90% of their expected body weight will resume their menstrual periods within 6 months. And in terms of fertility issues, it is safest to pursue pregnancy or fertility treatment once the person is in eating disorder recovery. The common complications that are seen are menstrual irregularities that we've discussed previously. This can be investigated using hormone levels, and ultrasound scan to evaluate ovarian maturity and uterine size. If the person is not desiring to take the contraceptive pill to use as contraception, then there is no benefit to the contraceptive pill being prescribed for menstrual irregularities that are seen in eating disorders. In terms of sexual dysfunction, this can present with low libido, pain during sex, and there's a role here for hormonal treatment. Fertility issues can be common in patients with eating disorders. Full eating disorder recovery should allow for the same chances of becoming pregnant as the general population has. It's also important to point out that eating disorders have higher rates of unexpected pregnancy, especially in terms of anorexia nervosa. There can also be risks in pregnancy, including miscarriage, and binge eating disorder is also associated with higher birth weight babies, regardless of the body size of the patient themselves. Anorexia nervosa can be linked to growth restriction in the womb, bleeding, and preterm birth. In terms of the musculoskeletal system, the most important complication here is osteoporosis and osteopenia, and that means low bone density, and this is also driven by the same hormonal shifts and starvation. Of all the medical complications of malnutrition, bone density loss is one of the few that may not be fully reversible. This bone density loss can lead to fractures, including permanent kyphosis, which is a curvature of the spine, which is due to spinal compression fractures. So it is advised that patients have a DEXA scan, which is a bone density scan, within 1 year of a woman losing her period in the context of anorexia or athletics. And with no loss of period, a DEXA scan is advised within a year of restrictive behaviours having started. Men with anorexia do lose bone density even faster and at a higher relative body weight than women, and fracture more easily than women also. Proximal myopathy is muscle weakness, which is often seen in starvation. This can be evaluated using the SUS test, which is a sit-up, squat, stand test. So it's important to highlight the increased risk of fracture in people who have a history of anorexia nervosa. This is thought to be 200 to 300% increased risk in fracture. Peak bone mass is reached by most people in their early 20s, and after this, the window shuts for further significant bone deposition. So it's important to bear this in mind for people that present with eating disorders in adolescence. In young people, it's also important to check that the growth plates have closed before commencing any hormonal treatment. Neurological complications of eating disorders. So this can be thought also to span psychiatric comorbidities that are seen with eating disorders, including depression, anxiety, OCD, PTSD, and substance misuse. Other neurological complications are cerebral atrophy, which is reduced brain volume. This can be reversed with weight restoration. Cognitive difficulties, such as difficulties with attention, memory, executive function, and processing speed. Peripheral neuropathy, which can present as tingling, weakness, and numbness in the hands and feet, is a problem with the peripheral nervous system due to vitamin B12 and thiamine deficiency. Seizures, as we've mentioned previously, due to low blood sugar or electrolyte abnormalities can also occur, and sleep disturbance is common, with malnutrition altering sleep architecture, causing insomnia and reduced REM sleep. In terms of the hematological or the blood system, the most common abnormality here is bone marrow failure of starvation. This is where the normal bone marrow is replaced by a non-cell producing gelatinous substance. So this can lead to a number of abnormalities such as leukopenia, which is low white cell count, and people with anorexia may not have an increased susceptibility to infection, but infections they do have can be more serious. There is also thrombocytopenia, which is low platelets. This can lead to easy bruising and prolonged bleeding. Impaired immunity due to reduced T-cell function, which can cause difficulties in wound healing. And also infections may not produce the usual response, like the person may not have a fever during an infection, as you would usually see. Anemia can be due to iron deficiency or B12 or folate deficiency. And with treatment and nutritional rehabilitation, the bone marrow usually returns to normal over several weeks to months, and these abnormalities can resolve. In terms of oral, dental, eye, ear, and skin complications, most commonly seen in the mouth is the erosion of the dental enamel, increasing the risk of cavities. The advice here is to rinse the mouth after purging with water or baking soda, and to avoid brushing your teeth for 30 minutes after purging to reduce the risk of cavities. There is a risk of retinal detachment with vomiting, and there is also a rare syndrome called lagophthalmos, which is the loss of the fat pad behind the eyes, which means the eyelids don't fully close. The skin can be dry and fragile and tear and bruise more easily. There's also lanugo, which is fine, downy body hair, especially over the trunk, as a protective response to hypothermia. There can be hair loss, which is most commonly telogen effluvium. This is diffuse hair loss about 2 to 3 months after the nutritional stress or the reduced nutrition, and that's due to protein and micronutrient deficiency. So it's important to realise that for anyone who is purging, any sudden visual changes should be treated as an emergency. Finally, I'll just talk briefly about weight stigma and weight inclusive care. This has come to the fore in recent years, and weight stigma is defined as the social rejection and devaluation that accrues to those who do not comply with the prevailing social norms of adequate body weight and shape. So this stigma based on weight was found to be common across medical settings and in lots of different specialties, and it is thought to form a major foundation upon which eating disorders are built. In terms of medical weight stigma, it has been found that there are worse health outcomes, including greater elevations in blood pressure, in blood glucose, chronic pain, avoidance of medical care, increased alcohol use and rates of depression, increase in eating disorders and substance use. So while it is accepted that higher body weight can contribute to cardiometabolic diagnoses, for example, type 2 diabetes, obstructive sleep apnea, hypertension, and cardiovascular disease, there has been a movement called Health at Every Size, which is laying the foundation for weight inclusive care among eating disorder clinicians. So weight inclusive care, the philosophy here is that people do not assume pathology in higher body weight. This philosophy honours body diversity and does not track body weight as a primary outcome, except in the cases of growing children, pregnancies, and those who are being monitored during nutritional rehabilitation. So weight inclusive care is thought to reduce stigma and improve outcomes in those with eating disorders. Finally, there's been an increasing amount of research on the links between physical health and eating disorders. So anorexia in particular is now being viewed as a metabo-psychiatric disorder. So this means a combination of a metabolic disorder and a psychiatric disorder. And this is based on genetic studies, metabolic studies, and even studies of the enteric microbial factors, which means a microbiome, the bacteria in the gut, and also psychiatric factors. So all of this is thought to contribute to the onset of anorexia. There was an experiment in the 1940s called the Minnesota Starvation Experiment, where a group of people volunteered to take part in a year-long survey involving starvation and then refeeding. And this showed that consistent undernutrition caused medical issues and caused also significant psychological distress. It induced food obsession and distorted body perception. So this showed that undernutrition alone can cause someone to develop the cognitive and behavioral patterns which are stereotypically associated with eating disorders. The metabolism or basal metabolic rate is dynamic, and it is dedicated to preserving the body weight status quo. So if there is insufficient food, things like heart rate, blood pressure, digestion, other organ function, energy levels, sex hormone levels, and cognitions are all altered to preserve energy. Finally, there's a theory that the awareness of physical health complications improves motivation to either enter eating disorder recovery or to remain in eating disorder recovery. And this is a quote from Dr. Gaidiani, who is a specialist who researches in this field in the US and specializes in the medical complications of eating disorders. She said, "I work to use objective evidence of body suffering to break through patients' denial of disease and help motivate recovery work." So in summary, eating disorders can lead to serious physical health complications. We aim for holistic care and a reduced distinction between physical and mental health. Prompt diagnosis and multidisciplinary team care significantly improves outcomes, and there needs to be communication between psychiatric teams, GPs, hospital specialists, and dentists. And many of the physical health complications can be reversible with eating disorder treatment and recovery. So that's all I have. Sinead, thank you. And I think we're going to take any questions that come in at the end. So I'll hand over now to Laura Griffin, who is an occupational therapist on our service, who's going to do the next portion of the webinar now. Thank you.
Hi everyone, I am just going to share my screen. Okay, so just here. Okay, so just thank you all for being here today. As is introduced, I'm Laura Griffin and I'm an occupational therapist working alongside the team here at St. Patrick's Mental Health Services on the eating disorder program. So I'm going to talk today about something that often gets missed in eating disorder conversations, the sensory and the neurological experience of eating, particularly for neurodivergent people. So occupational therapy supports recovery by helping you rebuild your daily life. It focuses on supporting you to take part in everyday activities that matter to you, such as caring for yourself, managing your day, moving your body, and gradually reconnecting with others. So we would work together to build a routine, confidence, and independence at a pace that feels safe and manageable for you. So as an occupational therapist, I look beyond behavior. So I don't just ask what someone is doing, I ask why they're doing it and what need it's meeting. That lens is particularly important when we think about eating. So I want you to imagine that you're sitting down for a meal. The room feels loud. Maybe there's a radio on, maybe someone else is talking, maybe there's something buzzing in the background. The lighting is quite harsh, it's maybe very bright overhead. Maybe the smell of food already is quite intense. Maybe it's that cooking sensation, maybe it's oils, maybe it's smells, maybe it's spices. On the plate in front of you, maybe the textures are quite unpredictable. So some things are soft, some things are crunchy, some things are mixed together, and you just don't know what the next bite will feel like. And you're expected to eat it all at a certain pace while sitting close to other people, whilst also making conversation. I suppose for some neurodivergent people, this isn't exaggerated. This is what meal times genuinely feel like. For them, eating isn't neutral. It's already very effortful. So when avoidance shows up, it's often about regulation, not refusal. And if we label that as resistance, we risk missing the fact that eating itself may already feel quite overwhelming. So what can this look like? When we talk about sensory sensitivities, it can sound quite abstract. So let's make it a bit practical. It might look like eating only beige or dry foods, not because of rules, but because those textures are predictable and they're known and it's what you might have always had. It might look like distress when a certain brand changes. Even if the food is the same, it can feel completely different. It might look like refusing foods that touch. So mixed textures, stews or casseroles can feel quite inconsistent and hard to tolerate. Why is that lump of beef a little bit bigger than that? Or size potato is a little bit maybe more lumpy than this other one. It can look like eating well in one setting and then barely eating in another. It can also look like coping really well in public, then maybe shutting down after that. You might see meltdowns after the restaurants, not because someone's being difficult, but because the sensory input has built up beyond their capacity. Sometimes food choices narrow during very stressful periods, so exams, life changes, transitions, burnout. When stress increases, tolerance drops. So from the outside, it can look maybe controlling, but internally, it's often very protective. This matters because autistic people are significantly overrepresented in eating disorder services. Yet the support they receive is not always adapted to how their nervous system works. So research, including work led by Kate Chanchuria here, shows that eating disorder behaviors in autistic people often serve as a function. They can increase predictability, it can reduce sensory input, and it can lower anxiety. So if eating is already neurologically difficult, eating disorder behaviors can become a way of creating stability. From an OT perspective, that's quite critical. If we focus only on removing the behavior without understanding what it's doing, we risk removing a coping strategy without replacing it. So my role isn't to push through the distress, it's to understand it and to adapt the task, the environment, and the expectations accordingly. And at the very end, there's just a slide of all the resources if anyone wants to take a picture of them. So, a common question, is it sensory? Is it an eating disorder, or is both? When something is primarily sensory driven, the distress is maybe around the texture, the smell, the temperature, or the unpredictability. When it's primarily eating disorder driven, the distress is more about the weight, the shape, the calories, or the body image. But on the outside, the behaviors can look quite similar. The rigidity, the avoidance, the repetition. But internally, the drivers are quite different. But often it's quite layered. That's why understanding the why behind the behaviors matters. Support has to match the driver. So we'll just take a closer look what we might actually see versus what actually might be happening. So on the surface, you might see rigidity, avoidance, repetition, or control, and that can look like defiance or non-compliance or stubbornness. But when we step back and consider maybe the sensory and the emotional load, those same behaviors usually serve as a function. They might be protecting the person from overwhelming situations or sensations. They might be creating predictability when things feel chaotic, or they might be regulating anxiety when emotions feel intense. And I just want to pause here because this part really matters. When eating becomes rigid or distressed, families and supporters often internalize the blame. So I just want to be clear about what this is not. It's not about bad parenting. It's not about laziness. It's not about manipulation. And it's simply not fussy eating. When someone is overwhelmed, their behavior is usually an attempt to cope. So avoidance, repetition, sameness, these strategies reduce unpredictability. They lower the distress and they create safety. So from the outside, it looks oppositional, but internally it often feels quite necessary. And when we understand that, the question changes. So instead of asking, how do we stop this? We maybe ask, what is this person trying to manage? And I suppose that shift from stopping behavior to understanding function is where effective intervention begins. So sensory needs are personal and changeable. One of the most important things to understand is that everyone's sensory needs is very highly individual and they change. Two people might both be neurodivergent with an eating disorder, but what overwhelms one person could be perfectly tolerable for another. And even for the same person, sensory needs fluctuate. So depending maybe on the stress, the fatigue, or the environment that they're in, a meal that feels manageable one day can feel impossible the next. So I'm sharing two resources, book resources with you on the screen. The first one is Looking After Your Autistic Self by Niamh Garvey. And the second one is the Autistic Burnout Workbook. I'll just share a picture of them both at the end. But both these resources remind us that self-care isn't about maybe mindfulness or face mask. It's about meeting your specific sensory and emotional needs in that moment. So for someone with an eating disorder, this might mean having the same texture of food, predictable meal layouts, or even just a quieter space to eat. These small adaptations aren't meant to be indulgent, they're essential self-care for their daily functioning. And here's what the key OT insight is. If we ignore these needs, we risk increasing the distress and inadvertently reinforcing the eating disorder because the body is simply trying to cope. So before I get into maybe some I just want to outline maybe some key research term, which is this term autistic burnout. So it's just more than tiredness. The author of the autistic workbook I just shared in the previous slide there describes it as exhaustion from masking or sensory overload or constant expectations. And Raymaker, the researcher within this area, I've left the link to the study at the very end, and I understand this the slides will be shared to all the attendees here. But Raymaker and colleagues define autistic burnout to be lasting months, so reducing function and tolerance to everyday tasks. And their research showed that burnout happens when life demands exceed what someone can manage. Some key findings is that it can cause skill loss, affect independence, and even increase the risk of self-harm. Isolation is worsened if others don't understand what's happening. So recovery isn't just about pushing harder. It comes from self-acceptance, supportive networks, realistic expectations, and embracing one's autistic identity. So far, we've looked at what artistic burnout is, and the research there just shows how profoundly it can affect daily life. But what does this look like maybe in practice, especially when it comes to eating? So during burnout, the nervous system is already overloaded. Sensory tolerance drops, rigidity maybe increases, and even tasks, as I said, maybe feel very unmanageable. So when we maybe assess eating, we maybe to look beyond the plate. And these are the 4 domains. So the first one is maybe the sensory experience of the food, the texture, the temperature, the smell, the predictability, the environment, the interoception, and emotional awareness, and then the burnout indicators. So looking first to the sensory experience of food, I'm just going some examples here. So texture tolerance, crunchy, soft, mushy, spicy, adding bland preference for maybe bland foods, such as maybe chips or potatoes or chicken tenders. Temperature preferences, food has to be a certain temperature, very hot, doesn't like maybe cold. Predictability, you know what you're going to get in the plate in terms of the portion. If there's a particular smell, that can be too overwhelming, or if the food leaves an aftertaste. So a very practical tool that I often use is what's safe for the for a person with neurodivergence, what maybe sometimes they can manage, maybe depending on maybe the stress or the activity or the environment that they're in, and what are some foods that they absolutely can avoid. So I just put some examples here on the screen. I suppose it's just to validate that preferences are valid. We all have them. And I suppose this is a very key part of building a sensory safe foundation first, and then the flexibility comes later. So looking then at the environment, eating environment, is it very noisy? Is there a lot going on in the kitchen? Is there sounds? Is the fan on? Is there maybe people coming in and out? Is the lighting very harsh? Is there an overhead lamp? Maybe is there light flickering? Is it a very, very dark space? Is it a very, very dim space? Looking at the visual clutter, is there a lot going on in front of you in regards to the dining table? Is it the dining room in a very busy room? Just using that example there on the image, is there a lot maybe visual clutter in regards to pictures and books? Looking at the seating is some people have a preference to sit with their back to the wall so they can maybe get an overview of the entire dining environment. Other people maybe prefer to sit in a particular seat because maybe there's a little bit more flexibility in regards to maybe moving around. And then the social demands, are they eating with family members? They're expected to talk and to maintain conversation. So just one very practical strategy just there is maybe, especially if this is something that is bothering people, is just to look at maybe for quick changes. Maybe the expectation is that they might eat separately to maybe the family members. Maybe they might use over the headphones just to reduce some of that overwhelm. Sometimes even just the recommendation I put on the screen there around loop earplugs, they're very subtle in case some people feel that the over the head headphones might be a little bit uncomfortable or tight on their head. Looking at interoception and burnout. So interoception is the ability to notice internal cues like hunger, like fullness, or like rising stress. So many people with autism struggle with this, and burnout can make it even harder. So even when the food and the environment is well managed, a person in burnout might not notice hunger or fullness, or they might shut down before they're aware of this distress. And I suppose that's just a clear example of capacity versus motivation. So what do we maybe do? Next step is just around reduce stress first. So we adapt first and then we challenge. As we're talking about laying the groundwork for some of those sensory environment pieces. So we might look at maybe deconstructed meals, so maybe keeping food separate. We might look at maybe making sure the texture is consistent as much as we can. Same with the temperature and maybe the repetition. If there's a couple of foods they feel comfortable with, building that in as part of the routine. Similar with environmental demands. So there's some practical tips if you're supporting someone. Reducing the sensory load before introducing maybe new foods, keeping the brand consistent, removing that pressure just to try it, and just validating discomfort. And if it's maybe this is relating to you, maybe just to track maybe patterns of overwhelm. Is social eating a lot more harder, going out to restaurants or coffee shops? Or maybe just identifying what safe foods that you feel comfortable with, and especially planning for decompression afterwards. Going to, let's say, if you're eating with your family or for friends, going to maybe a quiet space afterwards and just taking a few minutes to help regulate. Maybe that's just distracting on your phone or a weighted blanket or whatever that might look like. Looking then at just predictable routines can support eating, so anchoring meal times to time rather than hunger cues. So as you can see here, just on a sample timetable, using visual schedules, and just kind of working through with the person, maybe through collaboration. Keeping expectations clear and simple. So certain goals it might have. Okay, my goal every day now is to work on maybe 80% of getting through my yogurt. But as I was just saying on the slide here, please maybe consult with a dietitian to formulate a meal plan to your own specific needs. This is just a sample for just this presentation. But routines should scaffold capacity, not restrict it. And I suppose I just wanted to highlight it's important to seek specialist support if you notice any of the following here on the screen. Sensory adaptations are meant to be supportive, but medical safety always must come first. So support without overwhelm is about helping people engage without adding stress. This means planning together, giving advance notice of any changes, and offering choice within the structure. Would you prefer chicken tenders or would you prefer a stir fry this evening? It also means just avoiding surprises. So gradual exposure works. So if there's an event coming up, family commitments, friend commitments, giving plenty of notice to that person and what the expectation is. There might be a birthday cake or a pizza there, just so the person can maybe wrap their head around. Maybe they might have to eat beforehand or eat after, or maybe just having a conversation about working towards social eating. And the goal is predictable and collaboration. So support actually helps rather than add pressure. And then just a take-home message, there's 2 more slides to go. Just 3 key messages. Suppose we want to assess the sensory needs and burnout, not just the eating behavior. 2, we want to reduce the stress before increasing the challenge. And the third is looking at the adaptations. Predictability, autonomy, and regulation are central to recovery. It's about understanding, experiencing, reducing overwhelm, and so scaffolding capacity so change becomes possible. And yeah, these are just some of the resources that I talked through here on the screen. And I know we have some questions at the end. So just thank you for listening. And I hope today gives you some concrete ways to maybe support people. I'm going to now pass it over to Dr. Cooney next.
Thank you very much, Laura. Now, okay. So good evening, everybody, and thank you very much for joining our webinar this evening. My name is Gary Cooney. I'm the consultant psychiatrist working here in St. Patrick's in eating disorders. And for this evening, I thought I'd maybe choose something that's been quite topical lately, the rise of GLP-1 agonist medications such as Ozempic, and try to have a look at this from an eating disorders perspective. I suppose this year, the theme of Eating Disorders Awareness Week is all about connectivity and community. And there's no doubt about it that that's hugely important in terms of thinking about recovery, connecting with people around you. But sometimes in the spirit of balance, there can be mixed messages or maybe unhelpful messages coming back, particularly around body image, weight, shape, and size. And I think that's become probably something even more topical now, as I say, as we look into the increasing use of these GLP-1 agonist medications. As you'll have heard, they're being hailed as a real breakthrough medication in the treatment of obesity. And I suppose they're a rarity in terms of a medication being introduced into a population that's, has such an impact that we can see in the people around us and ourselves, the changes that are occurring. But I think it's important to take a step back for a moment and really, as I say, approach this from an eating disorders lens and be sure, are we making enough time, making enough space to think about the change in medical landscape that's occurring at the moment in relation to eating disorders. So for this evening's talk, I wanted to go through a couple of things. First of all, outlining what GLP-1 agonists are, how do they work in the body, how are they used in physical health management, in the treatment, for example, of obesity. I want to spend a little time thinking about the rates of their use and actually, importantly, the economic impact that's occurring in relation to the dissemination, the prescription of these medications. Then turning a bit to have a think about the overlap with eating disorder pathology, and thinking about a couple of current concerns arising in our own clinical practice relating to these medications before turning to a little bit about the research that's available for GLP-1s in relation to eating disorders. So yeah, just to conclude, as I was saying, just to conclude with a case study in relation to in relation to a patient in our own caseload here in St. Patrick's, for whom some of these issues are very pertinent. So what are GLP-1 agonists? Well, I suppose they are glucagon-like receptor proteins. They mimic the naturally occurring GLP-1 hormone that occurs in all of us. This is a hormone that's secreted in the gut, in the large and small intestine, and in the pancreas as well. And it's also secreted within the brain. Common trade names include Ozempic, Wegovy, Mounjaro, Saxenda, which you may have heard of. And these have a major role in appetite regulation, again, by neural pathways in the brain, but also in changes that occur in the body as well, through the stimulation of insulin, stability of blood sugars, and slowing of gastric emptying, and increased feelings of fullness as well. So overall, quite a powerful medication, having a role, as I say, in neural pathways together with in digestive processes, in the normal digestive process that occurs. So they're associated with substantial weight loss. Up to 20% is often quoted in the research. And subjectively, there's reports that there's also a reduction in people's experience of cravings or of food noise as well. But there's a wide side effect profile often reported too, particularly around nausea, stomach pain, constipation, and diarrhea. And I suppose these are very frequently reported side effects that occur on introduction of the medication and with any increase in dose as well. There's also reports that there would be a weight loss plateau. So people begin to lose weight and then that weight loss tends to stabilize and plateau. But there's research and indeed reports that stopping the medication can lead people to regain that weight that they have lost. And so people find themselves in a position of feeling the need to continue these medications for long periods. And I suppose, what's brought this into the public eye a great deal is just some of the high profile people who have, celebrities and so on who've been using GLP-1 agonists. There's been a lot on social media as well, a lot of influencers. But we can see here an image from People magazine from earlier this year, January 2026, of Oprah Winfrey, who writes very openly about her experience of GLP-1 agonists. And I just want to highlight a few things just in terms of some of the language being used. She talks about a transformative journey. You can see it's happy and healthy. So there's a description of this being beyond simply a medication treatment for a medical concern. But equally, looking at her quotes here, she says, I came to understand that overeating doesn't cause obesity. Obesity causes overeating. So it's a sense that's being reflected in the public health message as well, that obesity should be considered as a clinical condition, a medical pathology, a medical problem with a medication solution, rather than as it would have been maybe previously more considered in terms of lifestyle and dietary choices. And I suppose while there are advantages to that in terms of reducing stigma, there's a lot of research that would suggest, and we've heard this from Dr. Costelloe's talk earlier, just about the reluctance people have sometimes in larger bodies of accessing healthcare and some of the stigma associated with that. But I think there's a deeper complexity to that as well. Oprah writes here now that it's as if it's like my blood pressure medication. If my blood pressure goes up, it will go up if I stop taking that, and the same thing is true now with these medications. But I think it's probably worth putting it into a larger context that we've evolved a very finely tuned appetite regulation mechanism over, millennia. But it's only in the last sort of 20 or 30 years that we've come up against a food industry that's highly profit driven, and there's lots of highly calorific, highly dense foods with high sugar, high fat, high salt content, and that perhaps we are not evolved to counter some of the stresses of that profit driven system. And I think what emerges then is disorders such as obesity, and then we have medications to counter them. So thinking of it as purely a medical pathology really misses a larger point. But then that's, I suppose you would argue, is nothing new in that. There's a lot of medications such as statins or antihypertensive medications as well that similarly treat, conditions arising out of dietary issues related to maybe food industry too. So there's nothing new there. But I suppose what's different here is maybe just the power of some of these medications and the powerful impact they're having on people, and the connection that they have with their bodies as a result of that. The World Health Organization has recently issued guidance back in just at the end of last year in relation to the use of GLP-1 agonists, and again reframing obesity as a chronic relapsing medical condition with a medications treatment rather than something to do with lifestyle or dietary choice. And their recommendation is in the treatment of obesity with GLP-1 agonists, together with lifestyle, diet, and exercise modifications and supports, professional supports. And in the guidance, there's indication that obesity affects 1 billion people and associated with 3.7 million deaths worldwide. So there is, substantial evidence coming through now in terms of the weight loss, the reduced cardiovascular complications, the improvements to diabetes management, kidney damage, and so on, of reduced mortality coming through from the GLP-1 agonist use. So there's a lot to be, to celebrate in relation to the arrival of these medications. But I suppose it's about tempering the enthusiasm and remembering to kind of locate them within a world where there are high rates of eating disorder as well. I wanted to just, if I could, draw your attention to an article from the Irish Times there from last November. So I'm just going to, yeah, there was a surge in Irish exports from January to March 2025. Now, some of this was related to Donald Trump and the tariffs, but there was a rise of 153%, up to $71 billion surge in Irish exports, and 42.3% of that can be located back to a single ingredient in the production of Mounjaro, one of the GLP-1 agonist medications, from the manufacturing facility in Kinsale in County Cork. And this led the single ingredient, the single manufacturing product related to these medications led to the Irish economy expanding by 11%, making it the fastest growing advanced economy in the world. So I just wanted to highlight that, just the impact these medications are having. It's really quite unprecedented, just the impact they are having on people, but individually, but also on a societal and an economic level as well. And indeed, again, there's concerns as this happens in relation to what these medications may be used for going forward. This is an image taken from an advertisement that was aired at the Super Bowl in January this year in the US of Serena Williams. It's an advertisement for an online telehealth company which supplies people with GLP-1 agonists. And you can see here that Serena Williams is using this. She has spoken very much about difficulty with weight management post the birth of her second child. But, in advancing this, there's a leaning into, this product being used for fitness, success, beauty, status, wealth, these kind of things. And it is worth mentioning that her husband is on the board of the company that is supplying GLP-1 medications through telehealth. There was also mention in this ad of the emergence of a tablet or a pill form of the medication, which is being trialed now in US markets. And again, I think that will have some impact on availability and people's uptake on these drugs. So moving maybe to having a look, moving to take a look from an eating disorders perspective. I suppose it's important to say these are not the same as medications that reduce blood pressure. They occur in a context of, a lot of sociocultural drives around thinness and all consuming at times pathological drive towards thinness. And there's a muddying of the waters between that being the drive for people using these medications and the treatment of a clinical condition. And I suppose it's important when we think about individuals and their choices around these medications that we try to identify, subtle though it may be, what is underlying a drive towards the treatment with this medication. There's a process about reinforcing the social desirability of certain body types or an approval of certain body types, and perhaps potentially the reversal of a large drive around body positivity and drives towards self-acceptance. We've heard from Joan earlier about the health at every size movement as well, and just wondering a bit about whether this is running counter to that. Plenty of research suggesting that people can be very healthy at any size provided that there's good activity levels and there's a varied and balanced diet, that it isn't necessarily always related to their body shape or weight. And just really overall, the lack of discussion in the context of an eating disorder global population estimated to be about 70 million. And in preparing for tonight's talk, I wanted to have a look to see what research was out there in relation to GLP-1 use in eating disorder populations. And it was really quite concerning how little there was. It was actually limited just to case reports, individual case reports of GLP-1 use in eating disorder patients, without any wider research. But it is recognized, I suppose, in our work, certainly, and I think other centres would say the same, that there is an increased misuse of GLP-1 agonists coming up, and we're finding that as we meet patients. And this wouldn't have been maybe the case as recently as 6 months or a year ago. It's something that's coming up more frequently for us. And there's worries as well about counterfeit production of these medications available online as well. There was in the UK, there's been enforcement actions taken against 20 online pharmacies in relation to productions of GLP-1 agonist medication and being circulated without the proper checks and balances carried out. People are turning to AI to take photos and enhance those photos so that they feel able to qualify for these medications, for the prescriptions of these medications. So there are, definitely there's emerging evidence from a public health perspective of changes in patterns of behavior in order to get these medications, which again wouldn't be for the treatment of obesity. In Ireland, the Health Product Regulatory Authority removed over almost 500 websites in 2024 related to inappropriate prescribing of GLP-1 agonists, and they managed to intervene and recover over 1,500 GLP-1 products in 2024, which was almost 3 times the amount that were recovered in 2023. So it's definitely an emerging, concerning misuse of these medications, and that may become more of a problem as the drugs come off patent or as they develop in a tablet form. I suppose in thinking about the overlap with restrictive eating disorders, there's definitely this is an anorexigenic hormone. It stimulates satiety, reduces appetite, and we know that medication misuse, as we've heard, is well described behavioral symptom associated with restrictive eating disorders. We see that with the use of diuretics, with laxatives, and so forth. But the worry is that with rapid weight loss, there can be a reactivation of the anorectic drive. The rapid weight loss plus the feedback that people are getting, people, commenting on weight loss and commenting and saying that you look a lot better with the way you've improved your health, you're looking so much healthier, all this kind of positive reinforcement, reactivating a kind of an anorectic drive for people. The gut symptoms that I've described there as side effects very similar to those side effects that might be experienced through a process of a restrictive eating disorder such as anorexia. So it can be in some ways reminiscent of previous periods of restriction, of previous experiences of anorexia nervosa. And then there is also the concern that using these medications may interrupt treatment plans, meal plans have been very well established and may have an impact on an ability to remain in remission from an eating disorder. There's also the potential for people wishing to use these medications, because they're worried about future weight change, they're worried about gaining weight, and they have an anxiety about this. But rather than thinking about addressing the underlying cause of that anxiety, turn to a medication solution and maybe don't address what that original anxiety may be about. So I might finish up with just a consideration of a case example, a patient under my care who's given me permission to share her story with you today with anonymity. This is a woman who is in her 20s with a background of an eating disorder from her teenage years. She had an athletic and a modeling background, developed an eating disorder in her late teenage years, but recovered reasonably, really quite well from it. But in her mid to late 20s, gained quite a substantial amount of weight and really struggled to make changes to her diet to address that, and sought some help from a hospital specialist. She didn't give at that time, nor was she asked about any previous history of an eating disorder, and she was quickly prescribed Ozempic, and indeed offered gastric banding surgery as well. She ended up losing a substantial amount of weight, more than would be predicted or expected, which suggested that there was more at work here than simply the impact of the Ozempic, that there was a reactivation of anorexia for her. And it's been very difficult because at present she's currently against the recommendations we have for her for discontinuing the Ozempic. And she tells me that she gets frequent comments now about her weight and her shape. People frequently asking her if she's taking Ozempic, people coming up to her in clothing stores, commenting on her figure. All of this would be very, very new for her. She reflects in her own life if things that are changing in her own life, such as promotions at work, are due to her performance, or her appearance. She wonders if everything that's coming to her that's good in life is related to how she looks. And she says that she feels sad when people tell her she looks great because, she reflects that she needs to keep this going and that she didn't look great previous to this. Most of the time, she says, I think I need to lose more weight. And just a couple of quotes from her experience. She would say, overall, from a mental health point of view, I'm worse. I'm more fixated now on appearances, more obsessed with food. If I could go back to the start, I would not now take Ozempic, but I don't feel I can come off it either. She says people should tell you more about it before you go on it and assess your mental health as well. So it really does have an impact. So I suppose what I'm saying that, there certainly is a role for these medications. There's a powerful effect that they can have on people's physical health. We really need to tread cautiously in a world where people have an experience of an eating disorder because of the impact that can have, and that, the sense of reaffirming an anorectic drive that their value, their esteem is tied up in their appearance and in their weight. So just, I suppose, in terms of recommendations, I think we should always be asking about an eating disorder and discussing with anybody who presents seeking treatment with GLP-1 agonists. I think we go a step further and even carry out screening tests for eating disorders because of the impact, using these medications can have on the reactivation of an eating disorder. I think it's important to provide full information on the potential physical side effects of taking these medications and to have a very honest and open conversation about how a change in body shape may have an unexpected psychological impact, how it may reactivate anorectic drive, or it may lead to an evaluation of the self that's driven very much by appearances, which can make somebody feel even worse than they imagined they would. I think it's important to avoid reducing this to a medical condition, to accept the fact that change in body weight has a huge socio and cultural, connection as well, and that these things can't really be taken in isolation the way you might do in a blood pressure medication or a lipid lowering medication or something similar. And I think from our perspective, working in the field, we need more representation from ourselves in obesity treatment guidance, and particularly as these public health concerns emerge. So I think just lastly, thinking about research, we probably, and I would say certainly there should be a lot of funding for this research when we think back of the economic impacts these medications have, but we should be seeking, trying to figure out the proportion of those seeking or receiving treatment for a GLP-1. Have they an active or a historical eating disorder? Are there emergence of any eating disorder cognitions that are coming through on people who are taking these prescriptions? Is there any prevalence, or what is the prevalence of the abuse or the misuse of these medications, and how will that change when they're now available in tablet form? It'll also be interesting to hear the experience of GPs and prescribers. Do they feel pressure to, prescribe to counter a sense of food noise or food fear? And there's also, worth pausing and reflecting on the risks of people disengaging from eating disorders treatment, such as the patient I described earlier. If there is any kind of possibility of prescription discontinuation, will that have an impact on their decision to continue in treatment? So I'll take questions, any questions, of course, at the end. There's just a list of references for you there. But that's the end of my talk for the moment. I'll hand you over now to our last speaker, Michelle Ward. Thanks very much.
Thank you. Tonight I'm going to speak about binge eating disorder. We heard from Gary there about the prevalence of, I suppose, eating disorders in general in the population, about 70 million people worldwide. Unfortunately, some of the information and the stats that we have really only focus on anorexia and bulimia. A kind of more recent study shows that that's about 16 million people worldwide would suffer from anorexia or bulimia. So if you take that 16 million compared to the 170 that's predicted, we can really see that eating disorders are very widespread and a lot of the time underreported. We know also kind of from research and stats that binge eating disorder is actually the most prevalent eating disorder, while a lot of the focus is on anorexia and indeed bulimia. binge eating disorder is actually the most common eating disorder. And that was very much why I chose to speak about it this evening, because it's likely that you've come across someone with it. It might be something that you suffer with yourself, or you might be treating people if we've clinicians in as well. Going to starting off with just I suppose a definition of a binge, and it's, like I said, it's not a clinical term. It's one that I took from the dictionary. It's an unrestrained and often excessive indulgence. And I actually found it interesting that even in this, it's that they refer to eating in this. It's kind of an eating binge or a drinking binge, excessive consumption of alcohol or food. So even in a common dictionary that they're relating it back to food. And I suppose that even the word binge, we're using it an awful lot more frequently. You talking about kind of, a Netflix binge or a series binge that I binged on series, looking at things and kind of going, as opposed to just watching one at a time, you're watching numerous. So it's really kind of having that indulgence and excessiveness. From a more clinical point of view, and apologies for the very small font, but just wanted to include everything in this. This is the definition as set by the Diagnostic Statistic Manual. There's 5 criteria for binge eating disorder. The first is that there's recurrent, so repeated episodes of binging, maybe within a short period of time or a particular period of time, and that the amount of food is excessive for what would be compared to different circumstances or compared to what someone else might eat in that same period. There's also a lack of control during that episode, that you can't stop, that there's nothing that will stop you eating what's in front of you. The second criteria is that you typically in a binge would eat more rapidly than normal. You'd eat until uncomfortably full, eating large amounts of food when not physically hungry. A lot of the times people would say that, I ate my meals during the day. I had my 3 meals or my 3 snacks if they're working with us, and then I binged, so that they know that they've had their food for the day, and then they'd have something then on top and have a binge. Eating alone because of fear of embarrassment, and a lot of it comes back to this feeling of disgust, feeling very guilty, feeling excessive amounts of shame. So it's that kind of emotional side of experiencing the binge. Again, criteria 3 is the marked distress, regard to binge eating, and awareness that this is not what I want to do, this is not right, this is not something that I want to continue doing. The 4th criteria is about how often it happens, that it's at least once a week for more than 3 months. And the 5th is that there's no compensation for it. With other eating disorders, and Joan spoke about them earlier on, there's a compensation. They might make themselves sick, people might exercise to excess to kind of compensate for the binge. With binge eating disorder, there isn't that. There is increasing evidence that this is not a disorder of adulthood, as was kind of initially thought of, but can also be seen in adolescence and childhood. The average age of onset is really in teens to early 20s. However, it's recognised then that the earlier the onset is associated with worse outcomes and requires more complex interventions. The perceived quality of life and health are significantly lower in binge eating disorder than in non-binge eating disorder populations. And I think Joan spoke about kind of the various health complications earlier on. 50% of people who are diagnosed with binge eating disorder have a BMI in the overweight or obese range. There's also an association with poor impulse control, poor emotional regulation, and 80%, such a very high percentage, would have a lifetime prevalence of at least one other psychiatric disorder. And that could be addiction, again tying into the impulse control, or a mood disorder associated with it. And unfortunately, quite a high percentage, nearly 25%, will have attempted to end their lives during their lifetime. That's 4 or 5 times greater than in the healthy population. So we can see that with the binge eating disorder, there is that associated, like I said, psychiatric disorder or illness, that this is a very complex presentation that people are dealing with when this is when binge eating disorder is diagnosed. Binge eating disorder was first diagnosed in 1959, so that's in 1960s, but only came formulated diagnosis in the 1990s. It was first introduced to the Diagnostic Statistic Manual in 2005, so kind of quite a gap in recognizing it and having it included. Lifetime prevalence, so more common in women than in men. But again, as we heard, a lot of the eating disorders are under-recognized and under-diagnosed in the male population as well. So it's kind of keeping that in mind. And there is prevalence increase in individuals at a higher weight, which we spoke about. What triggers a binge? And I'm not facetious in putting up this. And for anyone that's present with us tonight that has experienced a binge, you'd be able to say back to me, like, there isn't one thing. There is never one thing that comes up. But some of the things that people would report back to us is that they're under eating. So maybe kind of, particularly if they've binged the night before, they'd be like, no, I've had that. I'm going to eat better. I'm going to eat healthy. So I'm not going to eat and until I have my dinner or until I have something healthy to eat. But unfortunately, that kind of leads to a binge if the hunger cues aren't there or hunger cues aren't read, and that sense of hunger is there. A dietary lapse, alcohol use, emotional distress, unstructured time, structured time, being alone, being with people. There's so many different things that can lead to a binge when we're speaking with and working with our service users. Feeling fat, gaining weight, premenstrual issues, premenstrual tension, again, the different time of the year. A lot of the service users around the Christmas time would say about how food focused it is. From Halloween, there's kind of run up to Christmas and the food and saving and all the various different things that come with that. So it's really, really difficult to pinpoint one particular thing that might cause a binge. It's important to kind of, I suppose, highlight that many people with eating disorders, binge eating disorder included, may look healthy, but yet are extremely ill. And again, coming back to what Joan was speaking about earlier on, they're associated with very physical complications in many body systems: cardiovascular, gastrointestinal, endocrine, hematological, neurological. Eating disorders hit off them all at various points. And severe complications can emerge at any time during the course of the illness. Unfortunately, the more chronic and severe the eating disorder is, the greater the likelihood of some physical complications. And as we saw, if people are getting diagnosed earlier in their teens or 20s, and if they've been dealing with the issue for long periods of time, we saw that that can lead to more complications, more difficulties in engaging in treatment, more difficulties accessing treatment, and more difficulties in relation to their physical health. An eating disorder is a health crisis, and it disrupts personal and family functioning. It is not just the person that is dealing with this. And earlier on, Laura kind of mentioned that as well, that it's rarely just the one person with the eating disorder that is dealing with it. The family are aware, they're seeing what's going on, and they're part of caring, they're part of funding all the various different things that go along with an eating disorder. It interferes with personal and family functioning. It can produce financial burden, especially when it comes to the likes of binge eating, that there's obviously food needed to be bought in order to binge on, and sometimes that can lead, speaking to some of service users, sometimes that needs to, if they're planning a binge or they're such high levels of shame around it, that they're driving to the next town, they're driving to the next village in order to shop or in order to get whatever they need, and then to binge on because they're so embarrassed. They don't want to just go down to their local Tesco where they're known or where they might bump into someone. So along with the cost of the actual food that they're buying, they're adding petrol costs and they're adding kind of mileage to what they're actually going to do. So there is a significant financial burden when it comes to binge eating disorder. Eating disorders interfere with healthy development, physical, socially, psychologically, and may interfere with intimate relationships and reproductive health. And again, Joan touched on that earlier on. So the treatment for binge eating, and it's a step care model. It's a multidisciplinary approach. It's rarely just, I suppose that's the way that we work in St. Patrick's. So it's not just one individual, but a whole team looking at all the various different aspects of someone's care. So we're looking at psychoeducational interventions, psychotherapeutic interventions, behavioral options, and pharmacological options as well. So from psychoeducational interventions, we're looking at improving understanding, reducing stigma and shame and isolation. And I'm saying that quickly, but I know that that's quite a significant part of the education and the uphill battle that we have in relation to eating disorders in general and binge eating particularly. Promote a deeper knowledge of the condition. So again, like I said earlier on, I took the opportunity to speak about binge eating tonight to promote better understanding, better knowledge around it and how prevalent it is in our community. Teaching skills, restriction avoidance, food monitoring. Psychoeducation can be delivered on an individual basis or in a group. And basic education can improve, it shows improvement in binge reduction and in impulsive eating. So psychotherapeutic interventions are the most validated and effective treatment in binge eating disorder. CBT, or cognitive behavioral therapy, focuses on basis of binge eating, the relationship between self-esteem and the excessive focus on body image. It is flexible and it's an adaptive approach, and it very good success rates with remission in about 50 to 60% of people who engage with a dedicated course of CBT. Both individual and group CBT show similar results, and there's good efficacy for self-help with CBT or guided self-help CBT. DBT, or dialectical behavioral therapy, has similar efficacy to CBT in BED. It really helps reduction, lowering concerns about food and body image, and promotes a stronger focus on emotional regulation and stress tolerance. And interpersonal therapy is particularly effective where the patterns in relation to negative effect might underlie the binge eating disorder. CFTE, or compassion focused therapy for eating disorders. This is the main approach used in the eating disorder service in our program for the psychology department. And I suppose compassion is defined as a sensitivity to suffering in others and with commitment to try and alleviate and prevent it. So it's very much working through that, and both as inpatient in daycare and in individual eating disorder programs, the CFT is the primary approach. Behavioral interventions then include dietitian support, looking at nutritional needs, meal and snack planning, it's very much not to promote weight loss. It's more about stopping the eating behavior, which is the binge. It's again promoting physical activity, a development of interests and activities. It unfortunately is unlikely to be effective as a standalone treatment. And it also is associated with higher dropout rates and lower remissions of BED symptoms. So the pharmacotherapy, there's a recommendation for lisdexamfetamine or topiramate. There's a limited recommendation for SSRIs or antidepressants. And the pharmacological treatment of binge eating and any comorbid psychiatric disorder would be recommended. There's a consideration of the role of the anti-obesity medications if necessary. But as Dr. Cooney's kind of talked about it, we're kind of very cautious around that and around the impact of such medications in treating BED, especially when we're unsure of the efficacy of them and the impact on treating someone with an eating disorder with such medications. There is quite a treatment gap when it comes to binge eating, and even as I opened up this part of the webinar just around the gap in the underdiagnosing of that, and even then for those that are diagnosed, there is still a treatment gap there as well. It estimates that only about 40% of those diagnosed actually receive a specific eating disorder treatment. An online survey found that only about 3% of individuals who met the criteria had received a diagnosis from a healthcare provider. And moving on from that, even fewer received treatment. And that's even in high-income countries, kind of in first world countries. We in St. Patrick's, for those of you that aren't aware, obviously we run inpatient unit, there's a daycare service and our Dean Clinic. We just recently, in the last number of years, we actually developed a specific binge eating stream. It came from the fact that we recognized that people with binge eating disorder didn't share the same experiences of those with other eating disorder subtypes. People found it very shameful to talk about their experiences, and that kind of compounded the shame that they felt about the binge eating disorder in itself, or their binges when they experienced it. And they were concerned when they were talking about their own experience of body image and binge eating would trigger others who were experiencing different types of eating disorder. And essentially, they fed back that they just didn't feel heard or understood. So a specific binge eating stream was developed in St. Patrick's. It's a 12-week program. It's a closed program, so it's just the people that are referred are on that specific program. It's a hybrid model. It's 2.5 days a week, so online and on site. And it helps service navigate and gain awareness around their difficulties in relation to binge eating with others with the similar diagnosis. The purpose is for development of skills and tools to manage difficult emotions as part of the program. That's just kind of I put up just the timetable just to give people an idea as to what how the breakdown is. And you can see that there's the group Compassionate Mind, which is like the CFT, which we spoke about, an OT group, which happens on site and off site to kind of help people manage to go out, normalize kind of the eating, normalize going for a coffee, having snacks, having treats as part of day to day. And obviously one of the big parts is the promoting positive self-image. So that's very much around the body image group. It's nursing led. Some of the self-help resources that we kind of signpost people towards is Chris Fairbairn's Overcoming Binge Eating. So that's one that we often kind of signpost people towards. There's DBT Solution for Emotional Eating. That's the dialectical behavioral therapy that I mentioned. and the cognitive behavioral therapy approach for bulimia nervosa and binge eating disorder. So they're there as well. That kind of comes to the end, and I'm very aware that I'm skidding in just as the buzzer is going to go. So on behalf of all the team, just I want to thank everyone for their time and attention this evening. It's great to be part of, I suppose, promoting awareness around eating disorders and part of the St. Patrick's Eating Disorder Awareness Week webinar. So thank you all very much.
Thank you very much, Michelle, and thank you to all of our speakers this evening. So this one came in then, Joan, on your presentation. So wondering when focus and measurement of weight is such a risk factor for feeling eating disorder, why is measuring a client's weight such a big focus of treatment, particularly inpatient treatment? Does it increase risk to focus on weight when this is not a measure of eating disorder severity? And is there a shift to focusing on health rather than weight?
Yeah, I saw that kind of in the chat. Yeah, that's a really good and very relevant question. I suppose I think that the weight measurement is necessary as a component of the nutritional rehab or refeeding process initially for that to be done safely. Because there's a lot of components there and it's a marker of a lot of things, including the glucose stores, feeding into safe management refeeding syndrome, and in terms of fluid balance. So I think it is important there, but I can understand the point that in terms of the health at every size movement, is that contradictory? But one of the caveats of the health at every size movement is that it still is recognized that there are significant changes in mortality at the extremes of body weight that still does exist. So one option can be that some patients prefer to be blind weighed if they're finding knowing their weight very difficult for them. So that can be an option in the initial phase of the nutritional rehabilitation.
Great. Thanks for that, Joan. Yeah, so there's a question there about how to delineate between autistic burnout sensory differences impacting someone's eating and a diagnosable eating disorder, which would require specialist ED care.
Yeah, so I suppose when someone is struggling with eating, it's just supposed to understand what's maybe driving the behavior. So I suppose sensory difficulties or autistic burnout are usually because of overwhelm, reduced capacity, or distress around the act of eating itself. While eating disorders are more about weight, shape, or maybe the calorie-related concerns, and often come with very, very severe, maybe medical risks associated with that. So often, if both factors are present, and in those cases, we would probably need support from both a sensory support and specialist eating disorder care, which is what we offer here at St. Patrick's.
Okay. I did actually see a question there. Somebody was wondering in terms of access to St. Patrick's for eating disorder treatment. Just to flag, obviously, the GP is always the first port of call. St. Patrick's primarily funded through private health insurance as well. So that's something that you discuss with your GP. But just to flag that as well. Okay. And then we are moving on to Dr. Cooney's presentation. I don't know, Gary, if you saw any in particular that you think, I think I could see you scroll in the Q&A box there. So is there any that have stood out to you?
Yeah, no, thank you. Some great questions coming up
Yeah.
there. Just very quickly, there was a question about does it have the same impact, the GLP-1s on the brain that you would see with anorexia nervosa? There's really good studies out there showing the brain changes that occur, and some of them reversible, some of them not with anorexia nervosa. I don't think we know actually the detail of that answer. It's a real lack of information and knowledge and research being done on this, which is kind of the concern, I suppose. And yeah, would be a very important question to be asking. There was another question about the case study and why have we not discontinued the medication? And I think it's a very important question. It's something that you're very concerned about. We have to continue to work very collaboratively with everybody that we have, on a case by case basis. We're not at a position to insist or enforce. If it was the case that things were very, very serious, we would probably take a different mechanism, a bit different approach. But I think working in eating disorders care, the collaboration is so key to that part that we would want to try to work with somebody in an agreement as far as we possibly could and keep that conversation going. fearful that the person may disengage from our service, I suppose, if we were coming at them from a bit different perspective. Those are the only two I saw. I don't know if there's anything else, Sinead.
Yeah, there's a lot in there. There's one, I suppose, not specific to weight loss medication, but I thought it was quite interesting. Is it possible to have a healthy relationship with food and remain a healthy weight in today's food industry climate when so much of our food is produced by hyperpalatable to make us overeat and buy more? Do we need to focus on reducing processed food to feel satiated?
I could go another hour on that one.
Yeah.
Like it really is such a serious point, though, and really thanking that person for that question. As you left my talk there, just my real concern is about we're missing the point a lot of the time with the food industry and the profit-driven food industry driving behaviors around eating and leading to eating disorders and leading to the use of Ozempic, etc. And really, are we not needing to think about that more widely? If you go down to your supermarket, just the aisles and aisles of food that so highly processed, so far removed from what you'd see in nature. And I think we really have to be thoughtful about what's going on in that. I think we talk a lot about eating disorders, obviously, in the presentation, but even those who do not qualify or do not meet the criteria for an eating disorder, I think it's vast. It's out there. Most people, I think, have a complicated relationship with their food, and with their body. And I think a lot of it stems from these larger socio and cultural issues that we maybe just see the tail end or the narrow end of the wedge there in our treatment work. But I think this is something, that impacts, wide segments of the population.
Absolutely. And then finally, is there a difference from binge eating disorder and emotional eating? We have a question there.
And again, is kind of it comes back to that criteria that I had up at the beginning of the slides. It's kind of, it's whether or not those specific criteria are met, whether there's kind of the frequency of it, whether there's different behaviors around it, whether there's compensation, how much is happening, are those other feelings of shame and disgust there with the binge. So I think it's going back to that. So, a lot of people eat emotionally at different times, be that kind of that they eat less or eat more. But for binge eating specifically, it's going back to that DSM criteria, and kind of being very specific around that.
Great. Thank you. Okay. So with that, we'll sign off. Thank you so much, everybody, for your time this evening. Thanks so much to our speakers and to all of you at home for attending. We hope you found it useful and informative, and there's some practical steps and information there that you can take away with you. When we do sign off in this evening's webinar, you'll see a link on your screen as well. So we're just inviting your feedback. We tend to do an event every year now to mark Eating Disorders Awareness Week. So we really welcome any feedback you have, any thoughts you have, help us inform our future events and improve what we offer. So that's it. Thanks again, everyone, for your time this evening, and take care.
Thank you.
Cheerio. Bye-bye.